It's suppose my lecture will be divided into two parts. The basic one, which discussed very nicely by Professor Ahmed, it will present the basics, which are about the magnitude of the problem, the incidence and timing, what are the high risk, how to assess this risk, what are the type of anticoagulant, what is the dose, what is the pharmacokinetic, how to diagnose, what are the complications, and then what is the treatment and prevention. And then we have to outline the role of anticoagulant in obstetric in general and what its indication, including the VTE, the antiphospholipid syndrome, the recurrent pregnancy loss, and ART and REF. And then what about the peripartum anticoagulation, and then finally case scenario. And so for the first half of the presentation, I will pass it and then go directly to case scenarios. My cases will be divided into patients who develop acute DVT, and then when we need prophylaxis for DVT, and then how to treat, and the cases with prosthetic valve, cases with recurrent pregnancy loss and antiphospholipid syndrome, cases around the peripartum, whether delivered vaginal or cesarean, and then the postpartum care. What about the future pregnancy if the patient developed DVT in the current pregnancy? We'll ask you about the next pregnancy. And then what are the DVT complications and how to avoid, and then how to manage or how to suspect the occurrence of pulmonary embolism. And we will present again the pregnant air traveler and patient with thrombophilia and patient with superficial vein thrombosis. And so these are 14 rare cases. We will discuss this case, but I need from the participant to be with me, if it is allowed, just one participant to answer each question. It's okay. Case number one, if you have a patient gravida 2 para 0 with nephrotic syndrome, and her age is 33 years, and she is in 13 weeks pregnancy or 30 weeks pregnancy, gestation, and the blood pressure is 150, 110, and the body mass index is 32. If the patient presented to you with painful swollen left leg or painful swollen lower limb, what is the possible diagnosis and what do you recommend? Any participant can answer. These are the options: to give no treatment, or to start low molecular heparin in the treatment dose until objective diagnosis, or to treat with unfractionated heparin, or to prescribe for her the low dose aspirin and elastic stocking. Any participant? Ragda, can we allow for the participant?
Please raise a hand to open mic.
And please be rapidly, because we have 15 cases. Each case will take about 3 minutes, and so any participant will answer. Yes. Marwa, what is the possible option?
A low molecular weight heparin in treatment dosage until objective diagnosis.
It's okay. What about prescribing low dose aspirin and elastic stocking?
I think this is, we can use it also.
Okay. Thank you, Marwa. The possible diagnosis is acute DVT. The patient has an acute DVT, and so we have to start the treatment, and we have to start the therapeutic dose. And then after starting the treatment, we have to confirm the diagnosis. How to confirm diagnosis? By compression duplex ultrasound. And if it is negative, you have to continue the treatment for 1 week, and then you repeat the investigation. And then if the entire limb, the entire limb is swollen red associated with back pain, you have to suspect iliac vein thrombosis. And if you suspect iliac vein thrombosis, you have to ask for magnetic resonant venography, MRI. Okay. In order to confirm diagnosis, you have the duplex and the color Doppler. The MRI, CT is not preferred during pregnancy. And so the proper option is no molecular heparin in the treatment dose until objective diagnosis. The recommendation is the low molecular heparin are the agent of choice for antenatal thromboprophylaxis, and low molecular heparin are at least as effective as and safer than unfractionated heparin. I will go back again to the same cases. Marwa, if the patient is 33 weeks, what will be the duration to stop the medication? And if the patient is 13 weeks, when you ask the patient to stop? Marwa, yes?
I will continue till postpartum period.
Okay, the answer is, or the recommendation is to continue for 6 months at least from the beginning of DVT. And so if the patient is 33 weeks, you have to calculate 6 months starting from the 30 weeks. But if the patient is 13 weeks, you have to continue 6 months, and you have to continue the 6 weeks after delivery, because as Dr. Ahmed said, that if you have 100 patients develop DVT, 50% of this patient will develop during pregnancy, and 50% will develop during the 6 weeks of puerperium. And so the main problem occur in the puerperium. Half of the cases which develop DVT develop during the puerperium, and the other half develop it during pregnancy. And so it's very important to know the gestational age at which the acute DVT develops. This is a recommendation by the Royal College. The other question is that why it is left? Marwa, left is common or the right one? And why? Dr. Marwa.
Yes.
Yes. Left or right?
I think left is common.
Left is more common than the right, simply because the left vein is compressed by the right iliac artery, and so the left iliac vein is more liable to develop DVT because it's compressed by the right iliac artery. The next question: what are the types of thrombosis?
Venous.
Yes, we have three types of thrombosis: arterial, venous, and mixed thrombus. The arterial thrombus is a platelet-rich thrombus. However, the venous thrombus is a fibrin-rich thrombus, and the mixed thrombus is a mix in between. And so there is no rule for aspirin in this patient. There is no rule for aspirin in this patient, simply because aspirin is antiplatelet and work for arterial thrombosis. And so the answer is low molecular heparin. There is no need for aspirin in this patient. To diagnose VTE during pregnancy, you have to depend on the clinical assessment by history taking, and then you have to examine the patient in order to see redness and swelling of the affected part, and finally to do visualization of the occluded vein. How to visualize the occluded vein? To visualize the occluded vein by color Doppler or MRI or venography, and if you suspect pulmonary embolism, you have to do what's known as pulmonary ventilation scintigraphy. Pulmonary ventilation scintigraphy. What is the treatment objective for this patient, Marwa? Why you treat this patient?
Has risk factor for DVT?
No, my question: to treat this patient, you have to treat it for the patient is liable for complication, which is early complication in the form of thrombus extension or fatal pulmonary embolism. This patient is liable for two early complications: the thrombus extension and fatal pulmonary embolism, and the late complication in the form of recurrence and chronic venous insufficiency. This is the treatment objective, and so you have to continue for at least 6 months to avoid these early and late complications. Thank you, Maru.
Thank you.
Another participant: if you have a patient gravida 6 para 5, 41 years, the body mass index is 27, 10 weeks of pregnancy, and right now she has acute appendicitis, and the patient is in need for emergent surgery. What do you recommend? You recommend aspirin prophylactic post-operatively, or you recommend intermittent pneumatic compression stock, or there is no need for pharmacological prophylaxis or prophylaxis with low molecular weight heparin? Any participant can help me for this answer? Yes? Ragda, can you open for the participant?
Okay. Please raise the hand.
The question: if you have a patient which in need for surgery, what do you recommend for this patient? if this patient is 27 body mass index, 41, let's say old age, gravida 6, let's say there is high parity, high age, high body mass index, and in need for appendicitis. No participant? Rada? No?
لا ما فيش حد عمل raise hand.
Again, the patient is in need for prophylaxis with low molecular weight heparin. Aspirin, again, is of no value in this patient because the patient, if develops thrombosis, it will be venous thrombus and not arterial and not a mixed thrombus. And so aspirin has nothing to do with venous thrombus. Replacement, the intermittent pressure compression could not replace the pharmacological prophylaxis, but you can advise to use it, but you have to give low molecular weight heparin. The recommendation by the Royal College is to give low molecular weight heparin. Case number 3, if you have a patient gravida 4 para 2, 30 weeks gestation, and the blood pressure is 150, 100, with a body mass index 33, and the duplex ultrasound confirmed the presence of DVT. What's your recommendation? Low molecular weight heparin for 6 weeks, or low molecular weight heparin on weight-based dosage without monitoring during pregnancy and in the postpartum period, or low molecular weight heparin on weight-based dosage but stop for labor or cesarean and continue in the puerperium, or low molecular weight heparin on weight-based dosage but stop for labor or cesarean and then continue in the puerperium for a total treatment period of 6 months. Yes, Chair. Participant. What is the proper option and why?
The last option, Dr. Low molecular weight heparin, actually she has many risk factors.
Yes.
She's hypertensive. Actually, she had definite DVT, and
Yes.
her weight is
BMI
is high, is more than 30. So
yes.
she has up to now 3 risk factors, and so will start immediately low molecular weight heparin, and will continue for 6 months.
Thank you very much for this answer. And so the proper option is low molecular weight heparin on weight-based dosage without monitoring in pregnancy and postpartum, but stop for labor or cesarean and then continue in the puerperium for a total treatment period of 6 months. The next case will present if the patient on therapeutic dose when to stop, and if the patient on a prophylactic dose when to stop, and then when to start again. I will present it later on. What about the option? The justification based on RCG guideline, the treatment of acute DVT should be for a total period of 6 months. Thank you very much for your answer. Again, what are the objectives of the treatment of acute DVT? To prevent early complication in the form of fatal pulmonary embolism and thrombus extension, and to prevent late complication in the form of chronic venous insufficiency and recurrence of VTE. Case number 4, gravida 3 para 2, treatment dose of low molecular weight heparin, approaching expected date and planning for vaginal delivery. How to manage? Patient on the treatment dose of low molecular weight heparin, and right now approaching the indicated for termination through the vaginal route. How to manage? You have to continue treatment with low molecular weight heparin during labor and delivery, or to stop low molecular weight heparin 24 hours before labor and delivery and do epidural or spinal anesthesia within 24 hours of the treatment dose as above, but use epidural and spinal anesthesia, or give low dose aspirin during labor and delivery. Yes. What?
Option B. Stop 24 hours before,
yes.
And after spinal epidural, it's according to guidelines, it's 12 hours from removal of the catheter of epidural, but anyhow, according to this option, it will be B.
Okay, you have to stop low molecular weight heparin if the patient on the therapeutic dose 24 hours. before labor and delivery, and do not use epidural and spinal anesthesia within 24 hours of the treatment dose of low molecular heparin. And so you have to stop 24 hours if the patient on the treatment dose of low molecular heparin. Thank you very much. How to minimize the risk of epidural hematoma. Regional technique shouldn't be used until at least 12 hours after the last prophylactic dose. Regional anesthesia shouldn't be used for at least 24 hours from the therapeutic dose. And so there is a contraindication to use the epidural and contraindication to use regional anesthesia, except after 24 hours of the therapeutic dose or 12 hours after the prophylactic dose. And low molecular heparin should not be given for hours after the use of spinal anesthesia or removal of the epidural catheter. Case number 5. If you have patient with prosthetic valve, gravida 3 para 2, 33 years, body mass index 36, with prosthetic valve, planning for pregnancy, what's your recommendation regarding the anticoagulant therapy? To continue the VKA during pregnancy and puerperium, or to switch to low molecular heparin on prophylactic dose, or to switch to low molecular heparin on the therapeutic dose, or none of the above? Yes?
Will switch?
Switch to low molecular heparin?
Will switch to low molecular weight therapeutic dose, and again after delivery she will be on warfarin again.
Thank you very much, Marwa. But this answer in reality is wrong. Why? The only 2 cases in which you have to give aspirin plus low molecular heparin include the prosthetic valve, and the second one is, yes, Marwa? The second one is patient with antiphospholipid syndrome, simply because in these 2 patient category, the patient are liable to develop the 2 types thrombus or the 3 types of thrombus, which include arterial thrombus, and so the patient is in need for something for the antiplatelet and VTE, and so the patient is need for molecular heparin or mixed thrombus. So patient with prosthetic valve or patient with antiphospholipid syndrome are in need for addition of aspirin, and so the treatment is none of the above.
This is in RCOG, doctor, or
in RCOG and in the ACOG and the academic, the American Chest Academy of this is the main recommendation by the 3 main responsible about this recommendation. But I'd like to tell you something. Heparin, what is the difference between heparin and low molecular heparin and warfarin in this patient? How to manage this patient? Yes, Marwa?
Me, Shireen, not Marwa, anyhow. In the first trimester, we'll stop oral anticoagulant for fear of anomalies can be accompanied with warfarin, and we'll start low molecular weight heparin. Again, in the second trimester and the beginning of third trimester, patient can be on warfarin, and in the second half of the third trimester, patient will be in low molecular weight for planning to stop it at the beginning of delivery or planned CS. This is what I read in the RCOG guideline, but first time for me to...
I'd like to tell you something.
Yeah.
You have to counsel your patient as follows. You have to tell your patient that warfarin is more effective than heparin, period.
Yeah.
And then you have to tell her that heparin is more effective than low molecular heparin. But warfarin is more superior for you, but more bad for your baby. Heparin is more superior for your baby, but bad for you. Low molecular heparin is less effective than both. And so for this patient especially, you have to counsel your patient and you have to tell her that the warfarin is more effective, but it carry a lot of problem regarding your fetus. The other question, what is the difference between warfarin embryopathy and warfarin fetopathy? You know the difference between warfarin embryopathy and warfarin fetopathy?
Warfarin fetopathy, it means anomalies which can be affect the baby.
No, warfarin This is the anomaly. But phytopathy, there is another thing known as phytopathy. Warfarin and periopathy occur in about 6%, in which the baby will liable to develop chondroplasia punctata, mid-face hypoplasia, short proximal limb, short pharyngees, and scoliosis. But about phytopathy, the baby will more liable to develop fetal cerebral hemorrhage and low IQ later on. And so you have to differentiate between warfarin periopathy and warfarin phytopathy. And this depends on the timing at which warfarin is administered. And so you have to tell your patient that warfarin carry a risk for the embryo, fetus, and so it is associated with what's known as warfarin periopathy in about 6% of the cases. And if you take it late in pregnancy, it is your baby more liable to develop fetal cerebral hemorrhage and increased risk of low IQ and neurological dysfunction. But again, warfarin is more superior for you, but more bad for your fetus and your neonate. And this is the news of babies with warfarin. Again, to sum up this point, can you summarize it, Shireen, for us? Yes, Shireen.
Which point?
How to manage a patient with mechanical valve.
Patient of mechanical valve actually will be on warfarin. I'll discuss with her that in the first trimester we'll stop the warfarin cause of the anomalies, and we'll start heparin. Like that, we'll start heparin, not fractionated low molecular weight heparin. Will continue all through up to the second half of the third trimester. Till second trimester we can start warfarin till the second half of the third. Again, low molecular low.
But you have to tell her warfarin will carry the risk for 2 points.
Anomaly, periopathy or phytopathy.
This is periopathy if you use it early and you will stop it. But if you use it late, it will carry the risk of cerebral hemorrhage and carry the risk of low IQ later on and some neurological dysfunction. Okay?
Thank you.
Thank you very much.
Time to know the phytopathy.
Thank you. What about patient at postpartum? If you have a patient gravida 2-para-1 diagnosed with DVT during her pregnancy on low molecular heparin dose, how to manage following labor and delivery? The patient is already diagnosed that she has DVT during the current pregnancy and on low molecular weight heparin right now. How to manage? You have to treat with low dose aspirin for 6 weeks, or start prophylactic low molecular heparin 4 hours after delivery, or remove epidural catheter and continue the treatment of low molecular heparin or oral anticoagulant therapy for at least 6 weeks, or start the prophylactic low molecular heparin after delivery, or remove the epidural catheter and continue the treatment dose of low molecular heparin or oral anticoagulant for at least 6 weeks with minimum total treatment dose of 6 months, or treatment of low molecular heparin after delivery or oral anticoagulant is not required. Yes?
See, because already patient has DVT.
Yes. Maro again. The proper option is C. Yes. Start prophylactic low molecular heparin 4 hours after delivery, and you have to continue for at least 6 months from the start of the process of active DVT. It's very important to remember that you have to continue for at least 6 months in order to prevent the complication, which include early complication in the form of fatal pulmonary embolism, extension of the thrombus, and to develop late complications in the form of post-thrombotic leg syndrome and superficial vein insufficiency. The option justification: to minimize postpartum hemorrhage, you give prophylactic dose of low molecular heparin, start by prophylactic dose 4 hours after cesarean or after delivery. Again, in the absence of significant bleeding. And then you have to start treatment dose to be resumed within 12 to 24 hours and continue for 6 weeks, because the highest incidence of pulmonary embolism is during puerperium. Again, if you have 100 patients that develop DVT, half of this patient will develop during pregnancy, during the whole 9 months, and half of them will develop the problem during puerperium. And so the period of puerperium is much more dangerous than the period, the whole length of pregnancy. We can start warfarin on the 3rd day postnatal. Yes, we can start warfarin on the 3rd day postnatal. Why? Because it does not cross the placenta. Low molecular heparin should be continued until the INR is greater than 2, and then for 2 days, and then you can start the warfarin. If you have a patient DVT complication, gravida 2 para 2 with a history of DVT in the 2nd pregnancy, presented with persistent leg swelling, heaviness, cyanosis, pigmentation, and leg ulcer. What is the possible diagnosis? What is the possible diagnosis? The case is known as a post-thrombotic leg syndrome, which is a remote complication of DVT. Which of the following is correct for patient like that? Post-thrombotic leg syndrome is uncommon following DVT during pregnancy. Post-thrombotic leg syndrome is unavoidable and cannot be prevented. Post-thrombotic leg syndrome is common following DVT during pregnancy and can be reduced by wearing elastic compression stock. Yes. What is the proper option? What is your option? What's your option?
C.
Yes? What's your option? Dr. Ahmed, what's your option? What's your option? Huh? One of our participants.
Reduce. I wait for one of the participants.
Well, any participant. What's your option? Yes. The proper option is post-thrombotic leg syndrome is common following DVT during pregnancy and can be reduced by wearing elastic compression stock, but not prevented. Can be reduced by elastic stocking. Randomized control data have shown that wearing graduated elastic compression stocking for 2 years can reduce the risk from 23 to 11. It's very important to tell you that the patient is linked to you more than the vascular. And so it's our problem. It's our job to tell our patient that if you have a DVT, you are liable to develop what's known as post-thrombotic leg syndrome, and simply you can decrease the incidence of the occurrence from 23% to 11% if you simply insist to wear this graduated elastic stocking. لو شراب الضغط يعني. But it's recommended for year. Right now, the timing is decreased. What about future pregnancy? Case number 8. Gravida 2 para 2. Her last pregnancy was complicated by VTE, delivered by cesarean section 1 week ago. Asking your doctor, what shall I do on my next pregnancy? هعمل ايه في next pregnancy? What's your option? Investigate for thrombophilia, advise prophylaxis with low molecular heparin in the next pregnancy, and advise the graduated stock for 2 years. Advise to start oral contraception 6 weeks after delivery. Advise that no further anticoagulant treatment is required and that elastic stocking are not necessary. Maro again, yes, what's your option?
Investigate for thrombophilia, advise prophylaxis with low molecular weight heparin in the next pregnancy for 2 years.
And I would like to tell you something in Arabic. اللهم قد بلغت اللهم فاشهد. احنا مسؤوليتنا موضوع البوست ثرومبوتيك ليك سندروم وهنسأل عليه يوم القيامة. And so the proper answer is investigate for thrombophilia and advise prophylaxis with low molecular heparin and the next pregnancy, and insist and tell your patient it's very important to wear the elastic stock for a long period of time in order to avoid the occurrence of thrombosis, ulceration, swelling, and post-thrombotic leg syndrome. And you have to investigate for thrombophilia. Thank you, Marwa. Postnatal review is mandatory. You have to avoid oral contraceptive pill. You have to investigate for acquired and inherited thrombophilia. You have to advise wearing graduated elastic compression stocking for at least 2 years. Case number 10. Gravida 2 para 1 who had DVT during her last pregnancy and has thrombophilia, presented at 13 weeks pregnancy in the current pregnancy. What shall you do? Low-dose aspirin and elastic stocking for the duration of pregnancy. Start low molecular weight dose according to her risk profile and according to risk assessment for VTE during the current pregnancy and puerperium, or start low molecular heparin in non-pregnant prophylactic dose. Yes. What is the answer? Yes. Yes. What is the answer? Huh? Shireen or Marwa? A case with thrombophilia. Yes, Marwa. What is the treatment dose? What is the proper option? Yes.
Start a low molecular weight heparin according to her risk profile for venous thrombosis during pregnancy and puerperium.
Thank you very much. There is no rule for aspirin in this patient. Elastic stocking is of no value in this patient. And so you have to start low molecular heparin according to her risk profile for VTE during the current pregnancy. Okay, and the proper option is start low molecular heparin dose according to her risk profile for VTE during pregnancy and puerperium. Option justification. Having thrombophilia with VTE in a previous pregnancy, consider the patient to be at a high risk for VTE recurrence. Thrombotic risk exists from the beginning of the first trimester and vary according to specific form of thrombophilia. Expert hematologist should be with you. Case number 11. Gravida 2 para 1, DVT during pregnancy, previous cesarean, 39-week transverse lie, required delivery by elective cesarean section. As Dr. Ahmed said, that pregnancy per se increased the risk of DVT, and vaginal delivery doubled the risk of pregnancy. And elective cesarean doubled the risk of vaginal, and emergency cesarean doubled the risk of elective. It's very important to remember this point. If the patient delivers vaginal, it's more liable to develop VTE. But if it is delivered by elective cesarean, this doubled the risk of vaginal. And if the patient delivered by emergency cesarean, it doubled the risk of elective. Gravida 2 para 1, DVT during pregnancy, previous cesarean, 39-week transverse lie, required delivery by elective cesarean. What's your option? Continue with low molecular weight heparin before and during operation. Stop low molecular heparin on the day of CS and start the prophylactic dose after the operation and continue with full treatment dose for 6 weeks. Start oral anticoagulant therapy immediately after cesarean for 6 weeks. It's a very simple question. What's your answer?
B.
Yes.
Stop. B. Stop low molecular weight heparin on the day.
Stop low molecular heparin on the day of CS and start prophylactic low molecular heparin after the operation and continue the full treatment dose for 6 weeks. Option justification. On the day of CS, the morning dose should be omitted. The thromboprophylaxis dose of low molecular heparin should be given 4 to 6 hours after delivery and continue for at least 6 weeks. Thank you, Maru. Oral anticoagulant therapy can be given from the 3rd day after delivery, and low molecular heparin discontinue if the INR is more than 2 for 2 days. Oral anticoagulant therapy require close monitoring because it's more associated with postpartum hemorrhage and hematoma. It's very important to tell your patient that if you shift the patient from low molecular heparin to oral, there is a slight risk of increasing the possibility of occurrence of postpartum hemorrhage and hematoma. Case number 12, superficial vein thrombosis. Following delivery, Miss Mona or Madame Mona has superficial leg vein thrombosis. What do you recommend? Bed rest and immobilization of the leg, low-dose aspirin and compression stocking, or in the case of proximal involvement of the long saphenous vein, treatment with low molecular heparin for 5 to 7 days. Yes? What's your option? What's the proper option?
C.
C?
Mm.
Thank you. In a case of proximal involvement of the long saphenous vein, you have to give your patient a prophylactic dose of low molecular heparin for at least 7 days. In reality, most cases of superficial vein thrombosis are self-limited and do not require treatment other than analgesia and mobilization. But some patients concurrently might have DVT or might develop DVT, and so a prophylactic low molecular weight heparin reduce the progression and recurrence of superficial thrombophlebitis. So the answer is to give low molecular heparin for a period of at least 1 week. Case 13, gravid 2 para 1 year after delivery, she developed DVT after a long journey from USA to Cairo. Present at 13 weeks in her current pregnancy. What will be the next step? Yes. Again, what about the pregnant air traveler? If you have a patient, gravid 2 para 1 year after delivery, she developed DVT after a long journey. Let's say the patient delivered and 1 year after delivery developed DVT after a long journey from USA to Cairo. Right now, she is 13 weeks in gestation, and she will ask you, what shall I do? You have to give low-dose aspirin and elastic stocking for the duration of pregnancy, or you have to ask her for doing investigation for thrombophilia, or don't do investigation for thrombophilia, or you have to start low molecular heparin on non-pregnant prophylactic dose. Dr. Shaimaa, yes.
ايوه هندي لو موليكولار ويت هيبرين.
دكتورة شيماء نقراها تاني. You start low molecular heparin on non-pregnant dose ولا investigate for thrombophilia. العينة دي the patient develop what's known as
investigate معلش investigate for thrombophilia.
Yes, you have to investigate thrombophilia because this patient might, we have what's known as thrombophilia threshold. Some patients more liable to develop thrombophilia than other, and even the factors of, there are many factors if you do thrombophilic screen. You have to do lupus anticoagulant, anticoagulant antibody, factor 5 laden, prothrombin gene mutation, and so on and so forth. But you have to know that some factor like factor 5 laden mutation is more associated with VTE than the lupus anticoagulant and cardiolipin. And so doing thrombophilia screen is very important, and based on this screen, you can calculate everything later on, and you have to do risk assessment and to adjust the dose according to the risk assessment sheet. Pregnant air traveler, I'd like to tell you that more than 45 million pregnant air traveler each year. Pregnant air traveler, air travel during pregnancy is generally accepted and considered to be safe. And most airlines allow pregnant women to the 36 to 38 weeks gestation. But if you have a patient complicated or there is multiple pregnancy, it's not advisable to air travel after 32 weeks. And so, what is the mechanism of increasing risk of DVT during air travel? Dr. Shaimaa, huh? What is the risk of increasing DVT during travel? Immobilization, yes. Yeah.
Immobilization.
Immobilization reduce the flow due to cramped position. Number 2, hypoparic hypoxia. Comparable to altitude of 2,040 meters, study shows that there is effect on coagulation. Again, when immobilization is increased in longer duration of flight. They say if you have a long duration for flight, in more cramped position, in window seat and sleeping during flight, and when other risk factors for VTE are present. Pregnancy-related factors like multiple pregnancy, preeclampsia, and ART increase the risk of DVT for pregnant air traveler. In obstetric history, operative diploma or postpartum hemorrhage increase the risk of VTE in these ladies. Thrombosis-related risk like history of venous thrombus or obesity and family history. These are the high-risk group who are more liable to develop VTE during air travel. Again, frequent flyer, less than 6 weeks after delivery, women with a history of venous thrombosis, and women with several known risk factors. And the question, how to decrease the incidence or the occurrence of VTE during the pregnant air travel? How to decrease? Dr. Shayma, Dr. Hisham? What is the recommendation? The recommendation is to encourage exercise, to encourage hydration, to ask for first class if there is a long heel travel. What's meant by long heel travel? More than 6 hours. And to discourage the behavior that will restrict movement, such as sleeping and taking a window seat or too tight clothes. High-risk subject, like history of venous thrombosis or non-thrombophilia or other risk, might benefit from a short period of long-liquid heparin for 1 to 3 days, starting 6 to 12 hours pre-flight. And so, if you have to calculate the risk, and if you find that there is increased risk of thrombophilia, there is increased risk for VTE, you have to give a dose of long-liquid heparin for 1 to 3 days, starting from 6 to 12 hours. Case number 14. On 11/11/2011, poor patient gravida 6 para 5, 41 years, with low socioeconomic standard, delivered by cesarean due to obstructed labor. 5 days later, she developed a painful swollen leg, and she asked help by a doctor, and she gave her antibiotic and analgesic. 2 days later, she developed acute dyspnea and hemoptysis. 6 hours later, the patient was transferred to ICU and died on admission. This is a real case. What is your option? Antibiotic treatment and do chest X-ray and ventilation perfusion scan. Start low molecular heparin in the treatment dose and perform X-ray later on. Start unfractionated heparin and antibiotic. What's your recommendation? What's your option? This patient developed acute pulmonary
embolism, life-threatening condition.
Yes, and you have
start low molecular weight.
You have to start the treatment. If you suspect, you have to start the treatment, and then later on ask for
ventilation, perfusion scan, and chest X-ray.
And ask for whatever you would like to ask about it. But you have to start the treatment. In clinically suspected VTE in pregnancy, pulmonary embolism, you have to start low molecular heparin if you suspect pulmonary embolism. Low molecular heparin is safer than unfractionated heparin during pregnancy. In order to keep it simple, for antenatal thromboprophylaxis, I'd like from all the participants to concentrate, because this is the sum of the 3 lectures. For antenatal thromboprophylaxis, low molecular heparin are the agent of choice. This is grade A. To confirm DVT, you can do duplex ultrasound or color Doppler or MRI. For treatment, low molecular heparin on weight-based dosage without monitoring during pregnancy and postpartum, but you have to stop for labor and cesarean and then to continue in the puerperium. For labor and delivery, you have to stop low molecular heparin and don't use epidural and spinal anesthesia within 12-hour prophylaxis of the prophylactic dose or 24 hours of the therapeutic dose. After delivery, you can start the prophylactic low molecular heparin 4 hours after vaginal delivery and 6 hours after or 12 hours after cesarean section, provided that there is no significant vaginal bleeding. For post-thrombotic leg syndrome, you have to ask your patient to continue wear the graduated elastic stocking for a prolonged period of time. For 2 years right now, the duration is decreased. For pregnancy with thrombophilia, you have to start low molecular heparin according to her risk profile. Pulmonary embolism, if the pregnant woman with VTE developed acute dyspnea, you have to think in pulmonary embolism and to start the treatment immediately, and then to ask for what I'd like to ask about it to prove or disprove the presence of pulmonary embolism. For elective cesarean section, stop low molecular heparin on the day of CS and start low molecular heparin later on and continue for at least 6 weeks. For emergent cesarean section with increasing age after 36, and if it is not elective, you have to give at least 5 to 10 days of low molecular heparin. What is the take-home message? If VTE is still the most common cause of maternal mortality and morbidity, and if VTE in pregnancy is often preventable, so thromboprophylaxis is worthy. And if DVT is common in many hospitalized patients, as usually clinically silent, screening at risk patient is neither effective nor cost-effective, and if pulmonary embolism is not possible to predict and usually occur without warning, often no potential to rescue your patient, so thromboprophylaxis is worthy. Again, you have to think in VTE and you have to think in thromboprophylaxis. وربنا يحفظ مصر من كل سوء.